Good morning, ladies and gentlemen. The topic of today's lecture is neutrophilic dermatosis. Since this is a very important topic that includes some very important diseases that are important clinically as well as in your exam, I have divided this topic into two lectures. So in today's lecture, we are only going to discuss two diseases, Pyoderma Gangrenosum and Sweet syndrome. And rest of the neutrophilic dermatoses, we will discuss in the lecture next week. So let's proceed with today's lecture. Neutrophilic dermatosis. The spectrum of disorders has following features. The histological features are dominated by neutrophilic perivascular and interstitial reaction that typically falls short of vasculitis. So, presence of vasculitis or neutrophilic vasculitis is not a prerequisite to call that disease a neutrophilic dermatosis. Usually, the neutrophilic dermatoses are classified on the basis of their histology, which is the presence of intense perivascular and interstitial neutrophilic infiltrate. Vasculitis, that is damage of vessel wall, may or may not be a feature of these dermatoses. A significant proportion of cases can be demonstrated to have reactive causes or systemic associations. And the systemic associations are mainly hematological, gastrointestinal, or drug-induced. Many of these disorders may coexist or occur in sequence in an affected individual. That means that more than one of these neutrophilic dermatoses can occur in coexistence, or they can follow one another. The neutrophilic process itself may in some cases cause systemic disease. We'll discuss this. So this slide shows the classification of neutrophilic dermatosis, and this is basically an etiological classification. The classical neutrophilic dermatoses are two, which are the Pyoderma Gangrenosum and Sweet syndrome. There are two more important dermatoses with an overlap of vasculitis, and these are Behçet's disease and erythema elevatum diabetum. Then there are neutrophilic dermatoses with a special link with gastrointestinal disease, and these include bowel-associated dermatosis arthritis syndrome, or BADS, pustular vasculitis or neutrophilic pustulosis, aseptic abscesses in Crohn's disease, pyodermatitis or pyostomatitis vegetans, peristomal pyoderma gangrenosum. Few neutrophilic dermatoses are associated with acne or pustulosis, and these are the Cephao syndrome or Papa syndrome. Then there are neutrophilic dermatoses that are associated with connective tissue disease or immune complex disease. And these include the rheumatoid neutrophilic dermatosis, palisaded neutrophilic and granulomatous dermatitis, relapsing polychondritis, Sweet syndrome like erythema gyratum repens, and figurate neutrophilic infiltrate in SLE. Further classification include paraneoplastic or typically chemotherapy associated. This include the paraneoplastic neutrophilic figurate erythema or neutrophilic acrine hidradenitis. Then systemic neutrophilic dermatosis, neurosweet syndrome. Other internal sites include myositis, pulmonary involvement, pericarditis, osteitis, which is due to deep Pyoderma gangrenosum, lymph nodes involvement, and splenic or other visceral involvement. Other extracutaneous neutrophilic diseases include peripheral ulcerative keratitis involving the eyes and neutrophilic paniculitis. Some auto-inflammatory diseases are also associated with neutrophilic-rich infiltrate. These include familial Mediterranean fever and hyper-IgD syndrome. There are some neutrophilic dermatoses which are not centered on blood vessels, and these include subcorneal pustular dermatosis or Snettel-Wilkinson disease, intraepidermal neutrophilic IgA dermatosis, neutrophilic urticaria, and some little doubtful terms that are neutrophilic spongiosis and neutrophilic sebaceous adenitis. Pyoderma gangrenosum. You all know it's a very serious and important disease which should be remembered and known to all the practicing dermatologists. Pyoderma gangrenosum is a rare, non-infectious, neutrophilic dermatosis commonly associated with underlying systemic disease, and diagnosis is based on typical clinical features. So in this statement, there are few important points to pick up. That is, Pyoderma gangrenosum is non-infectious. It's a neutrophilic dermatosis. That's why we are discussing it in this heading. And it is commonly associated with some underlying systemic disease. Clinical variants of Pyoderma gangrenosum. The first is the classical or ulcerative type of Pyoderma gangrenosum. Then the atypical forms include the parastomal, pustular, bullous, atypical, or granulomatous superficial. The variant include neutrophilic dermatosis of dorsal of hand and pyostomatitis vegetans. Diseases which are associated with Pyoderma gangrenosum, this is important because Pyoderma gangrenosum is usually always associated with some systemic disease. So the first diseases or group of diseases that are associated with PG or Pyoderma gangrenosum are the gastrointestinal diseases. And among them, the most important are the ulcerative colitis and Crohn's disease. Usually the Pyoderma gangrenosum associated with these diseases manifest as pustular lesions rather than large ulcerative lesions. Then arthritides. The arthritides that are associated with PG include rheumatoid arthritis, seronegative arthritis, sometimes which are associated with inflammatory bowel disease and osteoarthritis. Then some hepatic diseases like chronic hepatitis or primary biliary cirrhosis. Hematological diseases which are associated with PG include leukemia, especially myelogenous and hairy cell, myelofibrosis, myelodysplastic syndrome like polycythemia vera, hypogammaglobulinemia, IgE syndrome, paraproteinemia, and Waldenstrom macroglobulinemia. Usually, PG that is associated with hematological malignancies manifest as Bullous type. Solid organ tumors are also associated with PG, and these tumors include tumors of colon, pancreas, breast, bronchus, and carcinoid. Some autoimmune disorders are also associated with PG, and they include thyroid and diabetes mellitus. PG is also associated with other vasculitides or collagen vascular and related disorders like Wagner granulomatosis, Takayasu's arthritis, Behçet's disease, and SLE. Some acne-related PG includes acne conglobata or acne fulminans, hidradenitis suppurativa, PASH syndrome in which PG is associated with acne and hidradenitis suppurativa, and PAPA syndrome with recurrent familial arthritis. Few drugs may also induce PG-like lesions, And these drugs include colony stimulating factors, gefinib, which is an epidermal growth factor receptor inhibitor, interferons, propyl thiouracil, and isotretinoin. Then there are miscellaneous causes or associations that include depression, obesity, peripheral vascular disease, sarcoidosis, and infections that include HIV. Pathogenesis. PG is an immune-mediated process which has thought to have an important role in causation. Humoral defects reported include autoantibodies against skin and bowel. A dermonecrotic factor is present in the serum that produce necrosis when injected into subject's own arm. The serum factor present in patient with PG that produces PG-like lesions when injected into the guinea pigs. Pathergy is a phenomena whereby skin trauma provokes lesions or the first onset of disease at the site of injury. This most frequently follows a surgical wounds, surgical debridement, or penetrating injuries. There are several immune dysfunctions that are associated that include absent delayed hypersensitivity, defective neutrophil chemotaxis, and phagocytosis. There is increased interleukin-8, which is a potent neutrophil chemoattractant. Now the histopathology. There is no typical histopathology of PG, and early lesions display neutrophilic pustules. Ulcerative PG is characterized by loss of epidermis with central necrosis, and dermis is associated with intense neutrophilic infiltrate with a peripheral mixed chronic inflammatory infiltrate. There is a histological term that we call as pustular PG. It has a perifollicular, you can see a hair follicle here, a perifollicular neutrophilic infiltrate or subcorneal pustule formation. Then bullous PG. The bullous PG is associated with a large subepidermal bulla formation with neutrophilic infiltrate, both within the blister and underlying dermis. DIF shows deposition of C3 at dermoepidermal junction. Then vegetative PG. This vegetative PG, there is a granulomatous reaction surrounding the neutrophilic abscess with peripheral palisading histocytes and giant cells. So in the center, there is a neutrophilic infiltrate, and then there is surrounding granulomatous infiltrate. Such kind of appearance we see in atypical mycobacteria and deep mycosis, but both the two disorders which I mentioned are chronic disorders, but vegetating PG is an acute onset disorder. Vasculitis in Pyoderma Gangrenosum is a matter of debate. It is likely that any active inflammation of blood vessel is a result of surrounding inflammation rather than its cause. Diagnostic criteria. The major diagnostic criteria, both criteria should be present. And the major diagnostic criteria includes rapid, usually 1 centimeter a day, progression or spread of painful necrolytic ulceration with irregular and undermined and violaceous edges, which usually precede a papule, pustule, or a bulla, and pain is out of proportion to size of the ulcerated area. So it's a long criteria, and it includes the most important point in this criteria is a rapidly enlarging ulcerated lesion, and the size of the spread is approximately 1 centimeter per day. It is painful with well demarcated but irregular, violaceous, and undermined border, and pain that is out of proportion. And important is the second point, that is exclusion of other infective causes of ulceration. So it is must that we should exclude the infective causes and then think of Pyoderma Gangrenosum. The minor criteria, at least two are required. In first criteria, again, there are two subtypes. Either there should be a history of pathergy, that is occurrence of this lesion after some traumatic event, injury or surgical wound debridements, and or presence of cribriform scarring, pathergy or cribriform scarring, then presence of a disease known to be associated with PG, like inflammatory bowel disease, like polyarthritis, myelodysplasias or leukemia, then appropriate histological findings, and rapid response to oral corticosteroid therapy, that is at least 50% reduction in size by using 1 to 2 milligram per kilogram per day. Clinical features. The classical or ulcerative PG is the commonest and best recognized variant. This presents as a small, tender, red-blue papule plaque or pustule that evolves into a painful ulcer with a characteristic violaceous and undermined edges. So this is a classical ulcer of PG. But there may be exuberant granulation tissue, necrosis, and purulent exudate in the ulcer. Ulcer can be solitary or can be multiple, and associated symptoms include fever, malaise, myalgias, and arthralgias. Common site of ulceration is the leg, which is seen in 70% of the cases. Then another clinical type is the parastomal or peristomal PG. This arises as a pathergy response to trauma of appliance and fecal irritation. Most common with ileostomy for active inflammatory bowel disease. Risk is greater with high BMI, that is patient that is obese, a female sex, and associated autoimmune disorders. Pustular PG. It often occurs during acute exacerbation of inflammatory bowel disease. There are discrete painful pustules with surrounding halo of erythema on a normal skin, mainly seen on the extensor aspects of the limbs, and it must be differentiated from bowel-associated dermatitis, arthritis syndrome, subcorneal pustular dermatosis, and pyostomatitis vegetans, in which pustules are predominantly mucosal. Then bullous PG. It presents with rapidly arising superficial hemorrhagic bully, often located on arms. It shares clinical and histopathological findings with Sweet syndrome, but typically ulcerates and heal with scarring. Bullous PG is especially associated with myeloproliferative disorders, especially in old age. Then superficial vegetative PG or superficial granulomatous pyoderma. Most cases begin as single superficial ulcer with granulations and elevated edges. Lesions most often are affecting the trunk, more responsive to therapy like topical, intralesional, or systemic corticosteroids. Differential diagnosis. Pyoderma gangrenosum is always a diagnosis of exclusion. In non-classical Pyoderma gangrenosum, biopsy and culture are important, and we need to exclude vascular, occlusive, or venous diseases, frank vasculitis, bacterial infections, drug-induced or exogenous tissue injuries, defungal, atypical mycobacterial, and other opportunistic infections, drug-induced causes, and mycosis fungoides. Classification of severity. A simple measure is the size of skin ulceration, measuring the longest axis and perpendicular axis. Maximum width can be used to monitor the therapy. Formula used is length into width into 0.785. A periodic assessment is important to monitor the effectiveness of the therapy. Complications and comorbidities. PG has significant mortality, 16% over 8 years of age. Risk of death for those with PG is 3 times higher than general controls. It is not possible to determine whether this is due to complications of PG such as infection or management of PG with potent immunosuppressive agents, or the associated diseases with PG like anemia, renal impairment, thyroid disease, obesity, diabetes, peripheral vascular diseases, or other associations. So the cause, increased chances of mortality can be due to the disease itself, due to the disease complications, and due to the disease associations, and due to the disease treatment. Prognosis. PG is a chronic condition often taking many months or years to completely resolve. It occurs quickly, but goes very slowly. Once healed, PG may be recurrent at the rate of 16 to 61%, and consideration should be given to long-term systemic preventive therapy. Now the management. The first line management is the compression stockings, daily antiseptic dressings, pain relief, and topical agents for cleansing, debriding, and keeping the wound moist. For smaller lesions, potent topical corticosteroids or intralesional corticosteroids and topical tacrolimus is prescribed. Second line, for severe disease that is not responding to the first line treatment, second line treatment is, of course, systemic corticosteroids, which are the most frequently used treatment and is the mainstay of therapy. Systemic prednisolone in a dose of 0.7 milligram per kg per day is given, and cyclosporin 4 milligram per kg per day either alone, prednisolone alone, or in combination with cyclosporin is the preferred treatment. Other immunosuppressives include methotrexate, mycophenolate, mofetil, cyclophosphamide, chlorambucil, and azathioprine. Other anti-inflammatory drugs include dapsone, tetracyclines, thalidomide, tacrolimus, and colchicine. The third line treatment is the biologics, and there is a growing evidence to suggest that anti-tumor necrotic factor inhibitors should be considered as the first line treatment, particularly those that are associated with inflammatory bowel disease. The anti-tumor necrotic factor therapy include infliximab and adalimumab that brings healing in 4 to 8 weeks, while prednisolone take about 1 to 3 months. Etanercept has also been successfully used. However, paradoxical onset of PG has occurred with etanercept and with adalimumab. Ustekinumab has been reported as effective and in PAPA and PASH syndrome. Interleukin-1 RA agent have been successfully used that include anakinra and canakinumab. 7 out of 10 patients respond to intravenous immunoglobulin in one case series. Alternative therapies. They include aggressive surgical debridement, which is although contraindicated because of possible exacerbation of PG by pathologic response. Split skin graft and culture keratinocyte autograft have been demonstrated to be effective. Skin grafting can be very successful when inflammation has resolved. Hyperbaric oxygen therapy is reported to be beneficial. Topical sodium chromoglycate, topical nicotine. Recurrence may occur but are unpredictable and therefore do not justify prolonged maintenance therapy. The second disease which we are going to talk about in today's lecture is the Sweet syndrome, also known as acute febrile neutrophilic dermatosis. It's an inflammatory dermatosis that is characterized by non-itchy but tender erythematous plaques, most commonly on head and neck, arms, and upper body. There is associated fever and peripheral leukocytosis. The syndrome typically affects women in 3rd to 4th decades, 3rd to 5th decades. Histopathology is that of dense dermal neutrophilic infiltrate with edema. The 3 subtypes which are recognized include classical, malignancy associated, and drug induced. And etiology remains unclear. Types of Sweet syndrome, as already told, the first is the classical or idiopathic type that follows an upper respiratory or other infection, inflammatory bowel disease, and pregnancy. Thus, the condition is really not idiopathic. Then malignancy-associated PG or drug-induced PG. Sorry, malignancy-associated Sweet syndrome or drug-induced Sweet syndrome. Conditions that have been associated with Sweet syndrome include infections like streptococcal and upper respiratory tract infection, gastrointestinal infections, especially Salmonella and Yersinia, mycobacterial infections that include vaccinations. Inflammatory bowel diseases include ulcerative colitis and Crohn's disease. Endocrine causes includes pregnancy and autoimmune thyroid disease. Collagen vascular disorders include lupus erythematosus and Sjogren's syndrome. Hematological malignancies include acute myelogenous leukemias, myelodysplastic conditions, polycythemia, aplastic anemia, Fanconi's anemia, and monoclonal gammopathy. Other malignancies or solid organ malignancies include genitourinary, breast, GI, prostate, and larynx. Other medical conditions include sarcoidosis, rheumatoid arthritis, Still's disease, and SAPHO. Medications include colony stimulating factors, neutrophil maturation drugs, all trans retinoic acid, hematological treatments like imatinib and bortezomib, contraceptives, and propyl thiazolidine. Then associations with other neutrophilic dermatoses like PG, erythema elevatum diatinum, relapsing polychondritis, neutrophilic acarine hidradenitis, subcorneal pustular dermatosis, erythema nodosum, Behçet's disease, and various vasculitides. Pathogenesis. Tissue neutrophilic levels are controlled by following variables. That is, number 1, bacterial or fungal triggers. Number 2, bone marrow granulopoiesis, bone marrow neutrophil storage, bone marrow release of neutrophils, transendothelial migration of neutrophils, and decreased rate of neutrophil destruction. Changes in any of these will influence the development of Sweet syndrome. Histopathology. As you can see in this picture, epidermis is usually unaffected, and there is intense neutrophilic infiltrate in upper and mid dermis with significant dermal edema. The infiltrate comprises mainly of neutrophils, and in addition to the neutrophils, there is neutrophilic destruction like neutrophilic dust. Blood vessels show endothelial swelling, but frank vasculitis is absent. In bullous variety, there are frank subepidermal blisters or edema and with underlying neutrophilic infiltrate. In early form, there can be papillary neutrophilic microabscesses that may cause histological confusion with dermatitis herpetiformis. History. The clinical history is very important to establish a specific subtype. There should be a prior history of fever or infectious illness, current or previous malignant disease, and new drug administration. Clinical features. The patients are typically ill with persistent fever, increased neutrophil count, and high ESR. The cutaneous manifestations consist of erythematous to violaceous, tender, papules or nodules that are often coalescing to form large or irregular plaques. Plaques often coalesce into circinate or arcuate pattern. The lesions typically involve the face, neck, and arm, but may occur anywhere and usually are multiple. Later lesions may appear pseudo-vesicular and may also be studied with pustules, and in some cases, frank bullous forms occur. So in this slide, I have made the various clinical features or clinical types of Sweet syndrome in bold. So you should gather here that Sweet syndrome can present as papules, nodules, plaques, pseudovesicles, or bullous form. These plaques can cause pain and burning, but there is no pruritus, and lesions spontaneously resolve without scarring. This is important because, you know, I've already told before that in PG, the lesions always heal with cribriform scarring. But in Sweet syndrome, which many a time look like PG, especially the bullous types, will not leave scarring. Sweet syndrome is not so sweet. So you can see the intense number of erythematous, papules, and plaques that are involving the head and neck and upper chest in this patient. Lesions can occur be solitary and tender erythematous plaques. Pseudovesiculation is seen on the plaques, and sometimes the plaques are studded with bullae and pustules. This is a frank bullous type of Sweet syndrome. Close-up view of typical plaques with dried up bullae. Ulcers and bullae are more common in malignancy-associated disease than in other forms. These lesions can be extensive and generally are hard to treat. Photo-aggravated or photo-induced Sweet syndrome have also been reported. Healing usually occurs without scarring. Ocular manifestations are often found, and most commonly it is conjunctivitis or episcleritis. Oral lesions are uncommon in Sweet syndrome. Genital lesions may occur. And associated arthralgia is described in 1/3 of the patients. Atypical or unusual clinical forms include facial or giant cellulitis like necrotizing fasciitis type and Gotron-like papules. Extracutaneous Sweet syndrome. It is the specific involvement of other organs. CNS involvement is often called as the neurosweets that result in benign encephalitis, aseptic meningitis, brain stem lesions, and psychiatric symptoms. Then respiratory involvement include neutrophilic inflammation of bronchi or aseptic pulmonary effusion. Spontaneous resolution may occur often within 3 months, or a pattern of fluctuating exacerbations may be seen in untreated cases. Now the diagnostic criteria. Both major criteria and 2 out of 4 minor criteria are essential for diagnosis. Major criteria are acute onset of typical skin lesion and histopathological findings that are consistent with Sweet syndrome. That is neutrophilic infiltrate without vasculitis. Then minor criteria include fever that should be greater than 38 degrees centigrade or general malaise, association with malignancy, inflammatory disorders, pregnancy, antecedent respiratory or GI infection. Excellent response to corticosteroids, systemic or potassium iodide, and abnormal laboratory values. 3 out of the 4 are required, and these 4 are ESR more than 20, leukocytosis more than 8,000, neutrophils should be more than 70% of the leukocytes, and C-reactive protein should be high. For drug-induced Sweet syndrome, both major criteria and fever greater than 38 degrees centigrade is required. In addition to this minor criteria, that is fever, 2 additional criteria should be present: a temporal relationship between the drug administration and clinical presentation, and a temporal relationship between the drug withdrawal and the disease resolution. Clinical variants. The clinical variants include neutrophilic dermatosis of dorsal of hand that is characterized by bluish or hemorrhagic papule, bully, and nodule on dorsal surface of hands. The condition responds promptly to prednisolone or dapsone. Cases have been associated with myeloproliferative disorders, occult malignancy, inflammatory bowel disease, and rheumatoid arthritis. Sometimes it is difficult to distinguish it from bullous Pyoderma Gangrenosum. Subcutaneous Sweet syndrome is a very important variant. This entity presents with erythema nodosum-like tender subepidermal nodule on extremity like leg, presenting with hematological malignancies. Then histoid Sweet syndrome, that is characterized by an infiltrate composed of large histoid mononuclear cells that look like histocytes. This histologically mimics with the granulomatous variety of PG. Both hematological malignancy associated idiopathic and drug-induced cases have been associated. Clinically resembles classical Sweet syndrome or may present as subcutaneous erythema nodosum-like lesions. Differential diagnosis of Sweet syndrome include infections like erysipelas, cellulitis, herpes simplex, inflammatory lesions like paniculitis, Pyoderma Gangrenosum, syphilis, and tuberculosis, neoplastic like metastatic diseases, reactive erythemas that include erythema nodosum, erythema multiforme, or urticarial lesions, systemic diseases like Behçet's, lupus, bowel bypass syndrome, and vasculitis like erythema elevatum diatinum, polyarteritis nodosa, and granuloma faciale. Complications and comorbidity. Sweet syndrome resolves with no sequelae. Severe skin lesions with ulceration or with delayed treatment can lead to scarring, but generally the disorders is described as non-scarring disorder. Prognosis without treatment often resolves in 3 months. 1/3 of cases will recur. Response to corticosteroid is rather rapid. In this way, it is also different from PG, although PG respond to steroid, but the response is not as rapid as in Sweet syndrome. The treatment ladder. The first line treatment is systemic corticosteroids. That is 0.5 to 1 milligram per kg for 4 to 6 weeks. In addition, potent topical or intralesional corticosteroid may be tried for mild and localized disease. Second line treatment include dapsone 50 to 100 milligram per day, potassium iodide 300 milligram 3 times a day, and colchicine 0.5 milligram 3 times a day. Third line treatment include indomethacin, chlorambucil, cyclophosphamide, tumor necrotic factor antagonist, thalidomide, interferon alpha, cyclosporine, clofazimine, and intravenous immunoglobulins. Thank you for a patient listening of this lecture. I hope this lecture made you understand these two important diseases. So see you next week with part 2 of this lecture. So goodbye and have a good day.